So let's talk a little bit about the history of hospice. Where did it come from? Well, the linguistic root of hospice is shared with hospital and hospitality and those words. So what does that mean? Well, it's really words that reflect the meaning of shelter and respite and caring. And in fact, hospice was first known in the Middle Ages when religious orders created a sanctuary for pilgrims that were making the very arduous journey to the Holy Land. So that was the original term of hospice. In fact, I was just over there recently, and many of those hospices still exist. But in modern days, in 1905, St. Joseph's Hospice was created, and what happened was there were 5 Sisters of Charity from Ireland that were working in the very poor neighborhoods of London. And they were helping people really who were struggling and many people that were dying. And 2 donors came forward and provided them a gift of land and built a facility for them. And to this day in the East End of London, that hospice still exists. Many years later, in 1967, St. Christopher's Hospice was formed. And this happened because a physician, well, I should say, a woman who was a physician, a social worker, and a nurse, I guess she liked school a lot, Cicely Saunders, saw the need for this. She also was one of the first founders to recognize the need for the psychosocial and spiritual components of care that we see in hospice today, and also really embraced the aspect of family being part of the caregiver circle. In 1969 then, Elizabeth Kubler-Ross in our country wrote the book on death and dying. Many of you, I'm sure, have read that book. And she really spoke to the issue of and opened the social consciousness, I think, that dying was a natural process that needed to be embraced more readily in this country. Interesting enough, in it was the late 60s, Cicely Saunders was speaking at Yale New Haven Hospital on hospice, and Florence Wald, the Dean of Nursing, as well as Edward Dobahal, the Director of Religious Studies, overheard her presentation. And this really fueled their desire to develop hospice in our country. So in 1974, New Haven Hospice of Connecticut was the first hospice really established here. And it was established as an inpatient unit to be utilized by the entire state. So what is hospice care like today? Well, we've grown tremendously. Today we serve about 1.5 million patients annually. 38.5% of all deaths in the United States for any reason are with hospice. The average length of care with hospice is 69.5 days. It sounds like a fair amount of time. However, half of hospice patients are with hospice for less than 21 days, and 35% are only with us for 7 days or less. Now, we get a lot of referrals even on the very last day of life. And although we may have the opportunity to help with some pain and symptom control, it's very difficult to get to the issues of psychosocial and spiritual healing with so little time. And so a lot of what we need to do is figure out how to get people in at a more appropriate time so the greatest amount of healing and the greatest quality of life can occur. Today, 3 out of 4 hospice patients die at home. So again, compare that to 70% of the general population who die in facilities. That's quite a significant accomplishment. And cancer is no longer our primary diagnosis. It used to be. But now, just as it reflects the population, it's more chronic illnesses that are occurring more readily, as well as other illnesses that we will speak about. So what is this word called palliative care? Sometimes people want to know, is hospice palliative care, is palliative care hospice? How does that work? Well, it's actually, according to Oxford's textbook on palliative medicine, it's the study and management of patients with active, progressive, far advanced disease for whom the prognosis is limited and the focus of care is quality of life. So what does it aim to do? It wants to affirm life. It regards dying as a normal process. It neither hastens nor postpones death. It provides relief from pain and other symptoms. It integrates the psychosocial and spiritual aspects of care, and it provides support for the resident and the family. How do they compare then? Let's look at palliative care and compare it to curative care. Well, as curative care is more disease-driven and the prime concern is cure, with palliative care, you're trying to look at symptom management and comfort and quality of life. In curative treatment, frequently the doctor's in charge, the disease process is the primary concern, and there may not be a lot of choices. We really defer to medical judgment on what we should do next. In palliative care, the resident is in charge, and the disease process is secondary to the person. We're focusing again on quality of life, and this is where us as healthcare professionals talk with the patient and family about what interactions and interventions may be possible, and what are the consequences, and how does an individual want to live the last days of their lives. So when you think of things, medicine itself encompasses preventative care, curative care, as well as palliative care. And palliative care is a universe that hospice is a subset of. Hospice is a small circle within it. So all hospice is palliative in nature, but not all palliative care is hospice. You'll find out a little bit later as we talk about prognosis and that. Hospice is more towards the end of life. Palliative care, you can palliate symptoms of a condition that you may have your whole life. And therefore, palliative medicine is broader. It's still treating issues that cannot be cured, but it's to provide that support. So what have we found that patients and people with a terminal illness really want? Well, they want pain and symptom control. In fact, most people are more afraid of the dying process than the true death experience. Why? They're afraid of the pain and suffering that may accompany that. So they want good pain and symptom control. They want to avoid inappropriate prolongation of the dying process. Their fears are that it's going to be long and painful. They don't want to extend that. They want quality time with their loved ones. They want to maintain control. They want to be able to make decisions as long as they're able to make decisions, and when they can't, they want to have an informed loved one being able to make those decisions for them as well. They want the chance to put things in order, their life. They want to relieve the burden of caregiving on their family. They're very frightened frequently of this burden. They're frightened. We'll find patients that don't want to let go. They're ready to die. The family's ready for them to die, and frequently we have to ask the family to whisper to them, it's okay to let go. So now they're not only worried about the burdens of the family while they're there and needing care, they're worried about the burdens of the family after they leave. Are they leaving a loved one to be the sole parent for young children? What are the issues there? They want to maintain a sense of dignity. This is very, very important. And our patients really are concerned that they'll somehow be just caught up and not be respected and not be given that dignified care. And they also want to take the time, this important time, to strengthen the relationships of loved ones.